Hi, everyone. We're going to get started now. So I'm Dana Olsted, and I'll be moderating the session today. So this is a seminar for the O'Brien Institute for Public Health at the University of Calgary. And I'll just start off by acknowledging that the University of Calgary is on Treaty 7 territory, and the City of Calgary is also home to the Métis Nation of Alberta Region 3. So it's my huge pleasure to introduce to you Dr. Seth Berkowitz. Dr. Berkowitz is an assistant professor of medicine at the University of North Carolina at Chapel Hill School of Medicine in the Division of General Medicine and Clinical Epidemiology. He's a general internist and a primary care doctor. He studies the relationship between health-related social needs and health outcomes, and his current work emphasizes interventions that address these needs as part of clinical care and the health effects of policies that affect the distribution of unmet health-related social needs. And I just wanted to add kind of a personal note as to why we invited Dr. Berkowitz, and that's because, as you know, there's a lot of movement now to try to integrate consideration of social determinants of health within primary care. And myself and several colleagues, so Dave Campbell and Reed Beal and Eldon Spackman, were writing a grant for the Prius competition a few years ago, and it was about an intervention to address food insecurity among people who have diabetes, and it was in the context of primary care. And so as we were writing the grant, we kept coming across really difficult questions that we weren't sure how to solve. And so, of course, we would turn to the literature. And every time we did, inevitably, we were reading one of Dr. Berkowitz's papers. And we discovered quite quickly that he was one of the world leading experts in this area, if not the world leading expert. He's done a ton of studies in this area. And we kept asking ourselves, well, what would Dr. Berkowitz do in this situation? And eventually we thought, well, why don't we just invite him to be part of our team so that we can actually really benefit from his expertise directly. And we did invite him, and he agreed, and thankfully we got the grant. So now we're officially a team. So I will let Dr. Berkowitz now take it away, and I know we will all enjoy his seminar.
Great, thanks very much. And are the slides projecting okay? You can see them. Okay, great. Well, thanks so much. I'm really excited to be virtually with you guys today and to talk about this topic. It's one that I care a lot about. I always start just with disclosures. I don't think I have any conflicts. I have received research funding from the listed organizations and personal fees from the Aspen Institute as part of an exercise to sort of prioritize food as medicine type research. Also, just sort of acknowledge, so I'm a primary care doctor in my clinical role, and so a lot of this is, my bias is presenting this from the perspective of clinical medicine and in particular primary care. I know this is an audience where that describes some people's background, but there's obviously a much broader background in public health and in many other health-related disciplines here. So just to acknowledge that I do know the audience is broader than clinical medicine if you find me slipping back into my clinical medicine comfort zone. And then also, obviously, a lot of the literature I'm familiar with and where I've done work has been in the U.S. I think most things that we're talking about here will be applicable in the Canadian context as well. And there'll maybe a few areas where I try to highlight differences or things that I think may be different, but also just sort of acknowledging the Americocentrism, which is not based on any feelings of American superiority, but just based on the work that I know. So just to start, and I doubt this will be surprising for anyone in this audience, but I like to kind of start at the 30,000-foot view and then narrow down. So if you think about sort of the social determinants of health broadly, and I've put a WHO definition here that I won't read through the whole thing, but the key thing thinking about these being sort of big picture circumstances around distributions of things like money, power, resources at various levels. That's the social determinants of health. This is a large number of factors. I think they're at the macro level, and I think, as we all know at this point, really help shape the distribution of health in societies. These are certainly modifiable through policy, and we have lots of evidence to suggest that. I think in the context of clinical medicine and maybe even in sort of a local population health type sense, they're probably not directly modifiable. And instead, I think what interventions like the ones that I'll talk about, or one of the programs that Dana was talking about, these are responding to what I think of as health-related social needs. What I mean by this is that these are sort of the individual level social and material factors that influence health. These are sort of basic factors like food, housing, transportation, medications, and those kinds of things. And so I draw this distinction between sort of the macro level social determinants of health and health-related social needs, just because there's a lot of confusion, I think, in what people mean when they're saying social determinants, or if we're doing clinical programs to address quote unquote social determinants, what that is. And I don't say this to be kind of pedantic, but just to sort of set the stage for the kinds of things that I'm talking about. So here we're really talking about individual level social and material factors that influence people's health. When these needs go unmet, it leads to poor health. And for that reason, I think these health-related social needs are increasingly the target of clinical programs and programs in the population health and public health space as well. And of these, I think food insecurity is one where the literature around the harm of food insecurity is particularly well developed, and the literature around addressing food insecurity to improve health, although still certainly burgeoning and not well established, is maybe one of the areas that people have paid a lot of attention to. Food insecurity is inadequate access to enough food for an active, healthy life. Financial constraints are sort of the main driver of this, but it's not the only factor that goes into it. There are also issues of neighborhood food access, so what food is available for purchase in people's neighborhoods, or sort of their local environment overall. Issues of individual mobility, or if they have mobility limitations, transportation and other issues there. So these all kind of factor into it, even though I think financial constraints are probably the major driver of food insecurity. Pre-COVID in the US, about 1 in 6 individuals with diabetes were food insecure. And across the total of people with diabetes in the US, that's about 5 million people overall, so relatively large. And in the US, the prevalence of food insecurity in people with diabetes is about 1.5 to 2 times that of the national average of food insecurity. So I think the most recent pre-COVID numbers, like 2019, were about 11% of people in the US overall, and about 16 or 17% of people with diabetes were food insecure. During COVID in the US, we've seen a large increase in food insecurity, about 1.5 times what it was before. So that went from about 37 million Americans to 54 million Americans. I expect the level of increase to be the same for people with diabetes. So you now may be seeing 20% or even 25% of people with diabetes in the US experiencing food insecurity after COVID. I'll admit I'm not super facile with where to get representative Canadian statistics, so my apologies if I'm not using right numbers, but as best I could tell, in the 2017-2018, around 9% of the population in Canada was food insecure. And it looked like, from what I saw, that estimates during COVID were somewhat similar, which could speak to either an outstanding response to the pandemic, of which I would certainly applaud Canada for, or to me maybe not being able to find up-to-date stats that reflect hardships that people may have been experiencing. But certainly hasn't gotten better during this time period, and has gotten worse in the US and may have in Canada as well, though the estimates that I saw linked down there looked similar. In the diabetes context of managing diabetes, food insecurity is strongly associated with worse hemoglobin A1C control. So in thinking of it as a continuous variable, about 0.5 to 1 percentage point higher hemoglobin A1C. And if you kind of use an A1C greater or less than 9.0% as sort of a cut point of glycemic control that's very suboptimal, you see greater odds in people who are food insecure. So about 1.5 to 2.0 greater odds of having a A1C greater than 9.0%, which sets people up for diabetes complications. Also associated with worse blood pressure and LDL cholesterol, so part of the overall cardiovascular risk of people with diabetes. And not surprisingly, for these reasons, we see associations with diabetes complications. So both microvascular complications, including chronic kidney disease and retinopathy, and macrovascular complications, including coronary heart disease, congestive heart failure, peripheral arterial disease, and stroke. So, across almost any complication of diabetes you can think of, it's more likely to happen if you have diabetes and are experiencing food insecurity. Food insecurity disproportionately affects racial ethnic minorities and individuals with lower SES in the US. So just as some examples from US numbers, you have about 2.5 times increased prevalence of food insecurity in non-Hispanic Black individuals compared with non-Hispanic white individuals, and about 2 times increased prevalence in Hispanic individuals compared with non-Hispanic white individuals, and also about 2.5 times if you compare those with less than a high school diploma compared with a college degree or higher, as an indicator of socioeconomic status. And taking all this together, it seems like food insecurity is really one of the key pathways for disparities in diabetes outcomes, particularly racial, ethnic, and SES disparities in diabetes outcomes. It's important to note, of course, that food insecurity is not occurring in isolation. Again, lower income is sort of a clear driver in many situations. It co-occurs with other health-related social needs, including housing and transportation needs, and other adverse social circumstances like social isolation, all of which can play a role in worsening health. However, despite all of that, in epidemiologic studies that adjust for these factors as well as possible, we still see food insecurity having a significant association, which suggests that this really may be a causal factor in the differences in outcomes that we see. And some very interesting studies, including path analyses and using structural equation modeling, again, to kind of tease this out, do still find that food insecurity is associated with worse diabetes outcomes, even when accounting for other factors like low income and other health-related social needs. The way I think about how food insecurity may be related to these bad outcomes is through kind of 3 pathways. First, I think of what I call the nutritional pathway. So in this pathway, food insecurity it basically incentivizes consumption of foods that are cheap on a per calorie basis. And these are often heavily processed foods with high amounts of sodium, maybe fairly fatty, may have refined grains, and pushes people away from foods like fruits and vegetables, lean protein, whole grains. And so these factors are both associated with the development of diabetes, they're associated with increased adiposity and body weight gains that then lead to insulin resistance and increase the risk of diabetes. And if you have diabetes and experience these things, it's the same thing, particularly for type 2 diabetes, which is about insulin resistance. So by having increased adiposity, and then consumption of foods with sort of high glycemic load and things like that, you really likely are worsening diabetes morbidity through that pathway. There's also an important compensatory pathway. So this I think of as things like food medication trade-offs. So it's sometimes called the treat or eat phenomenon, where people may be choosing between buying their medications or buying food. They may have less focus on diabetes self-management as you're trying to just put food on the table, support your family, meet those needs. And so these trade-offs, I think, make it more difficult to manage diabetes. And finally, through a psychological pathway, food insecurity is highly aversive. It's associated with increased depressive symptoms, feelings of reduced self-efficacy, more diabetes distress. And so these are all things that just make it harder to manage diabetes, that sort of sap the cognitive bandwidth that you might need to focus on self-management, and in turn leads to increased diabetes morbidity. When you think of how food insecurity may affect treatment for diabetes, what are the key ways that we manage diabetes? One is through diet modification and weight loss for people who may be overweight or have obesity and are experiencing diabetes. This is difficult in the setting of food insecurity because of those financial constraints and the reasons that I just mentioned. Our other main way to treat diabetes is through glycemic lowering, or in particular to improve glycemic control for people with diabetes, is through glycemic lowering medication medications. As we just saw, food insecurity can reduce adherence to medications because of sort of treat or eat trade-offs and those kinds of things. So reduces the effectiveness of that as well. And as I mentioned before, you're sort of sapping the bandwidth that you need. If you think about it, managing diabetes is extremely complicated. People have to think about it all the time. It's difficult even in ideal circumstances. And if you layer on top of that things like worrying about where your next meal is coming from, it really just makes it that much more difficult. It also importantly makes management of diabetes riskier, in particularly through an association with the increased hypoglycemia. One of the characteristics of food insecurity is very volatile or sort of fluctuating consumption of food. In particular, it may be not that different from people who are food secure when money is available, and then if money gets tight, maybe towards the end of the month or something like that, food consumption can drop. If you keep taking the same dose of glucose-lowering medicines, particularly ones that have hypoglycemia risk, then you can increase the risk of hypoglycemia. And we consistently see that people with food insecurity and diabetes have higher rates of hypoglycemia, both self-reported and serious hypoglycemia that results in emergency department visits or inpatient admissions related to their food insecurity. So it's actually a safety issue in diabetes management as well. So I think at this point, the relationship between food insecurity and poor diabetes outcomes is fairly clear, but that doesn't necessarily mean we know what to do about it in all circumstances. And this, I think, has really been an active area of research over the past 5 years, and I think will be even more active over the next 5 years. And so we're sort of on the cusp of really, I think, getting a lot better evidence about what to do in this situation. I'm going to go through a couple commonly proposed strategies, all of which I think are plausible and are reasonable ones in their own situation. And talk about sort of what the evidence, both the rationale for them and what the current evidence for them is. Probably the most common approach is something that I call screening in linkage. So the idea is that you might screen for food insecurity in a clinical setting or perhaps in the community. And then once you've identified someone with food insecurity, try to link people to a community resource to help meet these needs. That could be a food pantry. It could be a food subsidy, so providing some extra money for food, or it could be through connecting people to community health worker programs. Another approach, and one that I've spent done some work with, is one called medically tailored meals. So this is actually the provision of food delivered to people's houses and providing food that specifically is tailored to their clinical circumstances, diabetes in this case, and may also include other comorbidities that people experience, so that people are getting kind of exactly the right food for their specific clinical situation delivered to them. I'll also note, although I won't talk too much about it in this talk, that there are other diabetes management strategies that likely are addressing food insecurity in some ways during the intervention, even if not specifically targeting it. So peer support programs are common and have great evidence showing that they're useful. And it's likely that if you're, are talking about barriers to diabetes management amongst, say, low-income individuals, food insecurity is coming up, and people are sharing strategies for managing diabetes in spite of it. So I think these approaches probably are addressing food insecurity in some way, but they're not necessarily the focus of the intervention, but still worth mentioning, I think. So in the US, at least, screening and linkage interventions are both kind of the most popular approach, I would say, and probably the ones where the most research activity is right now. An example in the US is something called the Accountable Health Communities model, which the US CMS, the Center for Medicare and Medicaid Services, their Center for Innovation that focuses on studying innovative or potential changes to CMS programs. So they've launched this Accountable Health Communities model, which is kind of exactly as I described, involves screening for health-related social needs, of which food insecurity is a key one, and then linkage to community resources like food pantries and other things like that. We actually just in December saw, so this is a large program, involves about 30 sites across the US. Each site is committed to screening like 75,000 people, not all with diabetes, but large large numbers over the course of several years. So we're just starting to get some evidence from this. And so far, the evidence has been mixed. People find high rates of food insecurity. There's some suggestion of benefit, particularly in terms of reduced emergency department admissions. But at this point, there's not a lot of other evidence of clinical benefit from either the Accountable Health Communities program or other screening and linkage programs. One study that I was involved in, much smaller than the Accountable Health Communities program, I think maybe 600 people or something like that, found benefits in terms of blood pressure and LDL cholesterol control, but no change in hemoglobin A1C. And fundamentally, I think these programs really, their success hinges on what I call the resource landscape, which is what resources are available to put people into. If you have great local resources that are not already at their capacity, that are very easy to access, that have convenient hours, that can provide a robust benefit to people, then yes, I think this is likely to be very beneficial. If you have resources that are operating on a shoestring, that are kind of maxed out, that people might have used already and are food insecure despite having used the resources, that are not necessarily tailored to the needs of people with diabetes, then I think it's less likely to have a clinical impact. May still be a good impact in terms of improving food insecurity or just providing support for people in a difficult time. So I don't want to discount them, but I think it's just likely that there's going to be a lot of heterogeneity in the effects of these types of interventions because it, again, depends so critically on the resource landscape, which is inherently local. Some places just have different resources than others. I'm going to pause or maybe divert attention from talking about interventions for just a few slides here and talk about screening for food insecurity, because this is kind of a question that comes up a lot. Should we be screening? If we should be screening, how should we do that? How often? Those kinds of things. I think for screening, if you're deciding you're going to screen, and I'll talk in a second about whether that's actually a good idea or not, then I think what's sometimes called the hunger vital sign, which is a 2-item screening question for food insecurity, is probably the one to go with. The full US 18-item USDA household food insecurity survey module is kind of the gold standard instrument. This is basically the first 2 questions from that and correlates very well with the full scale. So I think it makes for a very useful screener. It's been validated in a number of populations and is a useful way to go. There are other tools that I think are particularly useful if you want to screen for several health-related social needs, so not just food insecurity, but a few others, housing, transportation, et cetera. Most of them use, for their food insecurity section, use questions pretty similar to the hunger vital sign, but again, they can address some other areas. This is one from the American Academy of Family Physicians. There's another one that's commonly used called the Prepare Toolkit that's available at the link there. The tool used in the Accountable Health Communities model is a reasonable screener. And then in North Carolina, where I am, as part of our state safety net healthcare health insurance program called Medicaid, they're rolling out a new screener, and so this is a tool that I think works reasonably well. Most of these items really are fairly similar across instruments. There are subtle differences between them. None of them, to my knowledge, have been psychometrically validated, and that's kind of not, I think, what the designers of these instruments were going for. I think they're meant to just kind of pick up people who are in situations of need rather than really, measure a psychometric construct. And so, if you're in the market for one of these, I think any of the options are probably fine, and it's reasonable to just take a look at a couple options and pick the one that seems to fit your situation well. If you're doing screening, there's a question around how to document it. In electronic health records now, we're seeing an increase in having structured fields where you can document this. In the EPIC system since 2018, they've allowed this. Many others, eClinicalWorks and others like that, do have structured fields for this. So that's convenient. It makes it easier to do kind of population health or sort of, retrospective data polls and that kind of thing, rather than trying to find it in free text notes or something like that. Also in ICD-10, you may hear about these things called Z codes, which are meant to capture factors that influence health status and contact with health services. There's not really a ideal Z code for food insecurity, in my opinion. Two that are commonly used are these ones listed here: lack of adequate food and safe drinking water, and extreme poverty. So those are sometimes used. Excuse me. In the US, overall, these Z codes are not used very commonly. There's sort of efforts to try to get people to use them more. But to my knowledge, they're not in wide use yet, but that is an option for documentation. So I mentioned I talk a little bit about whether to screen for food insecurity or not. And I have to say, this is not sort of a slam dunk question, even as someone who cares deeply about food insecurity and thinks it is bad for health and thinks we should do something about it. I still don't know that universal screening, all people without any prompting at any clinical encounter is necessarily the way to go, because I think we have to think about this in terms of, any type of screening program, whether it's colon cancer screening or, abdominal aortic angiogram screening or anything you might screen for in health-related fields. You have to consider questions of what do we do with this information? If we're not able to make use of it, then maybe it's not worth the time to do it. You have to think about the balance of benefits and drawbacks. Here there's not risk of a biopsy or something like there might be with a false positive mammogram, but there still are drawbacks in terms of the time that it takes to screen, or discomfort that people may feel, or just sort of the opportunity cost. There are competing demands, so it may be that if you're better able to use the time to do something else, then maybe you don't spend the time on this. And then this question of screening interval, I think gets very complicated. People's food situation can change very quickly, so it's not implausible that you could be food secure one week and then insecure the next week if you lose your job or have a major unexpected expense or other sort of income shock or something like that. However, for many people, screening at every visit would certainly be overkill, and so it's not clear what the best way to do that is. So until these some of these questions are answered, and in particular thinking that even when they're quote unquote answered overall, those answers may not apply to every situation, I'm still not entirely sure that screening for food insecurity in all cases or universally is the right thing to do. However, I like to differentiate that type of screening from what I call assessment, which is what you might do in the normal course of a clinical encounter. So if you think of, say, you're managing diabetes, you may not screen everyone for food insecurity, but it might still be reasonable when formulating your treatment plan to ask questions that get at this, right? So if you're going to be prescribing someone a sulfonylurea that has high risk for hypoglycemia, you might want to know about whether food supply is constant over the month, or if there are periods of time where people think they may not be able to, sort of eat the same amount and want to adjust your treatment plan during those situations. So in that sense, I think food insecurity information can be used to contextualize the care you're providing, even if you're not going to do anything and are unable to do anything to directly address the food insecurity. So there, I think there's still use for assessing food insecurity, even outside of necessarily a screening program or sort of a universal attempt to screen. Another question that comes up a lot is, relates to the harms of screening. So might people feel stigmatized or put off by having these questions asked? I certainly think there are ways to do this badly. I'm sure people can mess it up, but overall, in studies, when done, empathetically, with a perspective of trying to care for people, it seems like it can be done sensitively, and in both quantitative survey work and qualitative work, patients tend to be okay with this. So I don't think there's any real barrier to asking people about this information, with, of course, the caveat that you want to do this in a sensitive and empathic way. A phrase I often use is "we ask because we care," and I think just to communicate the idea that we in sort of a healthcare sense are asking about this information because it may affect your treatment plan, or there may be something we can do to address it directly. I think that's basically what I've all talked about here. Okay, so jumping back into to interventions. So say you've decided that you're screening, and so you find someone who's food insecure and you want to try to use some community resources to help address that. What are some that you might choose? So an obvious choice is food pantries. So that's is a common model that people use. So screen for food insecurity and refer to a food pantry if positive. Unfortunately, as of yet, the evidence of clinical benefit for this is somewhat mixed. This is a paper of a relatively large, about almost 600 people, randomized clinical trial that was done in 3 food pantry sites in the U.S. that combined both provision of healthy food, fruits and vegetables at the food pantry with diabetes self-management education also provided at the food pantry. And it was successful in the sense of improving fruit and vegetable intake and reducing food insecurity, but unfortunately did not have a change in hemoglobin A1C compared with usual care. So that was a little disappointing on the A1C side, although certainly encouraging in terms of the change in dietary quality and the reduction of food insecurity. Another type of approach is to use food subsidies, so ways that make food more affordable for people. These can either be publicly or privately provided. The study that Dana was alluding to, that she was kind enough to invite me to join in for the planning process of, is a food subsidy type study. In the US, there's a program called SNAP, the Supplemental Nutrition Assistance Program, or sometimes called the Food Stamp Program, that is one of the larger specifically anti-food insecurity efforts in the US. And so that is a government provided food subsidy for people under relatively strict conditions. There's not a direct equivalent of this in Canada, although there are other types of public assistance in Canada that I think serve similar roles, even though they're not specifically, they don't say you can only use these benefits for food in the same way. But if you look at what is sometimes called the social wage, or sort of the overall package of benefits that are available to people, Canada actually does okay on that score. I've had Canadian colleagues say, oh, it's a shame that we don't have SNAP, but you kind of just do it differently. So, not that a food subsidy may not, direct food subsidy may not be beneficial as well, but anyway, I just add in that contextual piece. But a lot of what we know about food subsidies and their effect on healthcare utilization or health outcomes in the US comes from studies of the SNAP program. It's known that SNAP reduces food insecurity. It's unclear, but I would say the evidence overall so far supports the idea that there are probably SNAP effects on healthcare, at least healthcare use and cost, and possibly health outcomes as well. I'll go through a couple studies here that generally suggest that participation in SNAP is associated with lower healthcare use and cost, particularly in older adults who may be at particularly high risk for using expensive healthcare, like inpatient admissions or long-term care stays. So 2 groups in Maryland in the US have done great work on this. And then there's a study that I worked on as well using national data in the US. An interesting point that won't be super relevant to the Canadian policy context, but I think speaks to sort of a broader point about how to do sort of social assistance programs overall, is that in one of the studies in SNAP that I worked on, we used as an instrumental variable differences in how different US states administer SNAP. So it's a federal benefit, and so minimum standards are set at the national level, but each state kind of gets to decide how they do it. And some states make it easier versus harder to sign up. And so we used that variation as a way to study what happens when people participate in SNAP, but it also provides some guidance about just how to make these programs easier to use overall. And we basically found that if you do things that make it harder to sign up, like not having online applications, like requiring fingerprinting, like not using other types of eligibility information that you know about people, like if people are eligible for one means tested program, they're likely eligible for other similar means tested programs. If you can put all that information together and streamline the process, that's helpful and makes it easier for people. If you don't do that, if you treat each one as separate, then that makes it harder. So overall, there's evidence not only that SNAP is useful as a food subsidy, but that if you structure the program to make it easy for people to use and sign up for, and not do sort of really onerous administrative burdens to people, that you may see better effects with it. So far, there have been no evaluations specific to doing SNAP linkage interventions to improve health. So by that, I mean, we haven't connected the dots all the way from screen for food insecurity, find out someone's food insecure, find out that they're SNAP eligible but not using SNAP or some other food subsidy, and then connect them to it and see an improvement in health. So we have kind of pieces of the puzzle, but the whole thing hasn't really been put together yet. And then the last piece, and probably the piece in my opinion that has the strongest evidence at this point, is community health worker programs. Again, these may or may not, I would say in general, are not solely focused on addressing food insecurity, but if you have a community health worker program that is serving people with low income or high prevalence of food insecurity or something like that, you can bet that it's going to come, food insecurity is going to come up. And so these programs kind of are inherently addressing food insecurity in some ways. And I think there's really strong evidence at this point that community health worker programs improve diabetes outcomes for people with low income and who are at risk of food insecurity. And so I have an example of one study here that has demonstrated that, but there are certainly many others. So I think community health workers are one of the most evidence-based interventions in this space overall right now, even if the programs aren't directly or solely focused on food insecurity. There certainly are addressing it and doing a good job of doing so. To shift gears a little bit, now I want to talk about medically tailored meals, which I've abbreviated as MTM here. And as I mentioned before, this is home delivery of meals tailored to the specific medical needs of individuals. So these are types of programs that I've done a fair amount of work and will be doing some more over the next couple of years, thanks to some recent funding. And I'm excited about these, and I think they're different than some of the other approaches, and I think offer some potential advantages compared with other approaches. Again, not that they're right for everyone in all circumstances, but I think these are a unique and likely to be useful type of food insecurity intervention that we'll learn more about in the next few years. In delivering these meals to people's home and tailoring them to people's specific needs, it is both addressing the food insecurity issue. You're directly providing food. It also is kind of inherently providing some education by showing what a healthy meal that is at least what on the healthcare side we think someone in the person's medical situation should be eating. It provides an element of education there that I think can be leveraged. And also I think it's if you think about intensive lifestyle interventions overall, having models of healthy foods that are just delivered to people's home while they're going through the program, it is plausible to me that makes it more likely to be effective and maybe more useful. And so combining these things, leveraging the period of meal delivery as a way to do education and lifestyle change feels very promising to me overall. In the US, there are about 30 organizations that provide these meals, and an organization that you sometimes see that represents a number of these is the Food is Medicine Coalition. Many of these were founded in the late 80s and early 90s as a response to the HIV epidemic. So in particular, before there were good HIV treatments, malnutrition was really almost ubiquitous in people with AIDS. In many situations, particularly urban situations, people were sort of abandoned by their families during these times. And so these organizations rose to fill a philanthropic need. As HIV treatment got better, they have expanded out into other chronic conditions, and so are often providing meals for people with diabetes or cancer or chronic kidney disease or who are on dialysis, et cetera. The organization that I work with the most is called Community Servings. They're based in Boston, and this is a graphic from them. They are able to provide meal tracks that can be combined in up to 3 ways. So you can have a meal that's appropriate for diabetes and is appropriate for someone with end-stage renal disease, say it has low potassium, and say someone is on warfarin anticoagulation and needs a consistent level of vitamin K, they can provide that as well. So those combinations of the different tracks allow for very fine tailoring of the meals to the specific clinical situation that people are in, and I think offer the potential for real health benefits there. One of the things I think is really useful about this approach is just that it can overcome a number of barriers that people have. Any food insecurity intervention worth its salt should at least increase food access, right? So whether that's a food subsidy or a food pantry or a medically tailored meal, they should all do that. But what the meals can do that some of the other interventions may not be able to is remove some other barriers. So you don't have to go out and pick the food and shop. You don't have to do the meal preparation. You don't have to know what the right portion size is. You don't have to know what the healthy foods are. And so by combining all of these things, it feels plausible to me that medically tailored meals may have more impact on health than than some other types of interventions, and thus may be useful in the right circumstances. And then a thing that I think we shouldn't discount is that, you know, this modeling aspect of just seeing what a healthy meal looks like can be really useful. You know, people have been you know, eating in a particular way their whole life, and then once they develop diabetes or other you know, clinical conditions, and in particular a combination of several clinical conditions, it can be really hard to change those patterns that people are used to. And, you know, a pamphlet or you know, 1 or 2 sessions with a registered dietitian nutritionist is likely to be helpful, but may not be sufficient. And so I think having examples of foods and full meals that are useful for people is again likely to be helpful. For an earlier study I worked on was a pilot study of medically tailored meals for people with food insecurity and diabetes. So this was a 24-week crossover where people received meals for 12 weeks and were off meals for 12 weeks, assigned at random. People were provided with 10 meals a week delivered to their homes. That's about half their weekly intake. If you think 3 meals a day, 7 days a week is about 21, so 10 meals provided is about half. And for this study, as a pilot, our goal was to see whether this improved diet quality as measured by the healthy eating index total score, with the idea being that if people aren't eating the meals or it's not really affecting the diet, particularly as you're only providing half of the input for the week, then it's not likely that you'll see any other health benefits that would justify a longer study. For this particular scale of diet quality, it's a 0 to 100 scale where higher is better and 100 is the best. The mean for individuals on this scale with diabetes across the US is about 52, and we think a 3-point improvement or so is meaningful. In this study, the mean age of participants was almost 60 years old. It was about 2/3 women. 54% were non-Hispanic white, which for the US is considerably below the average. So population representation would be about 70%. So this had a higher proportion of racial ethnic minorities than you would otherwise expect from the population overall, but about what you would expect given that we're focusing on individuals with food insecurity. The mean A1C was a little over 8, and the mean BMI was 33. And what we found was that medically tailored meals were strongly associated with improved diet quality. So off meals, the score of this healthy eating index was about 40, so about 1 standard deviation below the mean for people with diabetes, representing worse diet quality. On meals, it was about 2 standard deviations above the mean, so a 3 standard deviation difference. And so this was really a large improvement in diet quality. You know, it's in some ways, you know, a bit of a no-brainer. People don't have enough food, you give them food, they eat it. But I think it's an important proof of concept, and also the magnitude I think is really important. So other food subsidy type interventions have shown increases in healthy eating index by about 4 points. So this suggested that there's really a large impact on diet as part of this approach, and that may be associated with other changes in diabetes outcomes like glycemia and other things. We also found a pretty strong reduction in food insecurity, and as an important safety outcome, a reduction in hypoglycemia. So both of those I think are really important. Probably unsurprisingly, but still important to demonstrate that people reported improved mental health. You know, when you're in a situation not worrying about where your next meal is coming from, and just qualitatively, people reported that having a lot less stress, better understanding diabetes appropriate diets, and finding this a very beneficial thing to have participated in. This study as a pilot was not designed to examine hemoglobin A1C control, but we did see a suggestion of improvement, about a 0.4% difference from baseline that was not statistically significant in this sample, but of a magnitude that would be important were that to be you know, not due to random chance, as we might try to demonstrate in a larger study. So on the basis of this, we now have 2 larger trials of medically tailored meals that we're just gearing up for and hoping to recruit our first participants for soon. One will be for individuals with diabetes, HIV, and food insecurity. The other is for people with diabetes and food insecurity, but not HIV. In Philadelphia, there's a group that has an ongoing medically tailored meal trial for people with diabetes, as does a group in San Francisco. So I think we're going to see a lot more information about specifically around the medically tailored meal approach in the next couple of years, in addition to sort of all the great food insecurity research that's going on with many different types of intervention strategies like Dana alluded to. So with this ongoing, where are things headed next? So first and foremost, I think is establishing efficacy for these interventional approaches. So that needs to happen. And that's sort of what this current iteration of studies are meant to do. Beyond that, then I think understanding how contextual factors interact with food insecurity interventions will be really important. So in particular, thinking about social circumstances like the composition of households, are there young children, are there older adults in the households, et cetera. Thinking about how these relate to other health-related social needs and how that may affect things, and whether combinations of food insecurity interventions are useful. So in the US, you can get SNAP and get a medically tailored meal. Are there ways to use that as a synergistic way to increase benefits is an important question, I think. In medically tailored meals in particular, if we are able to establish efficacy for sort of what we think of as the default approach, there are a lot of variations that I think can be studied. How many meals per week should be provided, what types of diets, we say a diabetes appropriate diet, which in our studies is mostly sort of a DASH-like diet, but you could use a Mediterranean style diet or other types of dietary approaches that may be useful. There could be differences in the education component provided. So lots of different variations that I think would be useful to test and figure out what an optimal way to do this might be. And then more importantly, I think are these kind of comparative effectiveness questions. So say we're in, what I think of as maybe not the best case, but a good scenario where we have a number of food insecurity interventions that seem to be effective. Linkage to food pantries helps, food subsidies help, medically tailored meals help. We've learned this and have solid evidence for all of them. Well, which one do you use when? There may be some people who don't need a lot of additional support. And so something like food subsidies or linkage that are a little bit lighter touch, maybe lower cost, may do very well for people. And so that works great. There may be other folks who need more support or have other barriers that that other interventional approaches won't address. And so medically tailored meals is what they need. So I think we're likely to get in a situation where, we're studying heterogeneous treatment effects. How do treatment effects vary across different groups in the overall population? And then once we know that, we can really do the comparative effectiveness work that says, all right, if you're, in this situation, here's the intervention that we think is likely to be best for you. It's of course, so I've spent a lot of time here talking about, kind of the nitty gritty individual level, clinic-based interventions for food insecurity that are trying to address particular clinical outcomes. One's related to diabetes. In my case, other people are doing works related to, say, maternal child health outcomes or many other outcomes there. And these are, I think, important because, we're seeing people who are running into clinical problems because of their food insecurity. And so from my perspective as a primary care doctor and from the perspective of many people in the audience, providing clinical care, you want to address that. But we also need to think about the bigger picture as well. So food insecurity, of course, does not occur in isolation. The distribution of food insecurity is rooted in the political economy of any given society. That affects both the overall level of food insecurity, why is the rate 11% and not 5% and not 20%? But it also impacts what groups experience food insecurity. Why do racial ethnic minorities in the U.S. have higher rates of food insecurity? These are questions that are rooted in the political economy. In the U.S., highly related to systemic racism, highly related to income inequality and sort of the distribution of income. And I think so it's important to think about why situations are as they are. When thinking about policy approaches for food insecurity, I think there are probably at least one of three things that a successful policy approach will do. May do more than one, but at least one of these things. One, you probably need, you can provide some short-term economic stability. So people are often food insecure when they're in an unstable economic situation. So can we stabilize that? The second approach is sort of advancing long-term economic security. So, across the life course or over longer periods of time, are there things we can do to labor policy, tax policy, things like that, that provide support so that people are not finding themselves in a situation of food insecurity in the first place? And then in particular, I think it's very important to address disadvantages that structural racism assigns. So if you think of the first two things as, maybe affecting the overall level of food insecurity, addressing structural racism is an important way to think about the distribution of food insecurity. Why are some groups more likely to be food insecure than others? This is my attempt to do what the kids are doing these days and make a meme. So this is my policy approach in meme form. And I think the basic idea here is that you need to use public policy to kind of spread societal resources into areas of high economic security, whether that's a marginalized community, whether that's a period of illness and people are unable to work and support themselves, or whether they're experiencing job loss, as we're seeing in the COVID pandemic. We need to distribute these resources more evenly to sort of smooth out people's consumption of the goods and services necessary to maintain health, of which healthy food is a key one. So wrapping up here, and I know I want to leave some time for questions because we have to finish right at the hour. So food insecurity associated with both greater diabetes prevalence and worse diabetes control, likely worsens diabetes control through at least three pathways: a nutritional, a compensatory, and a psychological pathway. A quip I sometimes use is that when I started studying food insecurity, I thought it was all about the food, i.e. the nutritional pathway, but I've since learned that the insecurity is actually a really big component of it as well, the compensatory and psychological aspects of how people deal with the situation that they're in, I think are really important to understanding the associations with poor health. And then also just to mention that food insecurity assessment can be an important part of contextualizing diabetes care, even if you find yourself in a situation where you don't think you're able to address the food insecurity in and of itself. You can always use it to make your care more contextualized and more congruent with someone's circumstances. And so I think can be useful to ask about for that reason. In terms of the evidence base, I think we are in early stages, but I think clinical interventions to address food insecurity are really promising, and we'll increasingly see these as part of diabetes care. But I think we shouldn't lose sight of the bigger picture, and that these should work in concert with policy interventions to address the overall distribution of food insecurity and the level of food insecurity in a society. So I'll wrap up there. I've got my email if people want to ask other questions or talk offline, and then I know there are a few questions in the question and answer box as well.
Thank you so much, Dr. Berkowitz. That was fantastic. And we have lots of questions, so we will get started with them quickly. So the first question is whether you know about the uptake in the US of produce prescription programs for diabetes, chronic disease prevention.
Yeah, so that's definitely a burgeoning area of research, and those can kind of be structured in one of two ways. One is kind of as a food subsidy, so people are offered $30 a month or something like that is a common amount that can be used to purchase additional fruits and vegetables or other things, either at a supermarket or a farmer's market or something like that. Alternatively, sometimes people can prescribe deliveries of kind of healthy food boxes and those kinds of things, not necessarily prepared meals or medically tailored meals, but just a delivery of healthy foods to people's homes. Those are becoming more common. I have not yet seen a lot of evidence on changes in clinical outcomes. The evidence around changing food consumption, though, is stronger and generally suggests that people will improve consumption of fruits and vegetables with either sort of the food subsidy type approach or the produce delivery approach. I think yet to be seen whether that translates into improved clinical outcomes, but certainly plausible. I mean, I think the association between a healthy diet and better health is very strong. So I do think that's a promising strategy.
Another question is in Alberta Health Services, that's our regional healthcare provider. They've chosen to use a single item question. It's the poverty screening tool. You're familiar with it, I think. It's basically an income-based question that doesn't actually ask about food, and they're using that for that reason, because they want the interventions to be income-based and not food-based. And so they're wondering what you think about that approach as opposed to using the more food security specific questions.
Yeah, I think it's all about what you want to do with the information, basically. And so, I mean, I think there are a couple of factors that go into it. What interventions you have to offer are important. What outcomes you're trying to target are important. And so, I can certainly think of situations where the income information is what you need to, you have a means tested intervention, or you're targeting your intervention specifically at an income level and not for food insecurity per se, or depending on the clinical outcome. I think that's perfectly reasonable. I think the key thing about all these things is we shouldn't focus too much on one screening question or what a specific screening question is, and we should more focus on the overall program that it's part of, and all the parts of that program need to fit together well. The assessment should feed into what you do with the information. It should lead to an intervention that is likely to change whatever outcome you're trying to improve with the program, and all these pieces need to fit together. So I think programs that are based on income or poverty type screening can certainly be reasonable, depending on what you're trying to do.
And do you think these interventions have a role as healthcare interventions targeted at preventing or mitigating chronic disease complications, or do you think they should actually really be implemented more at a population level to more broadly address food insecurity?
I think we need both. I don't see this as an either or question. Again, I think they certainly, in my opinion, have a role in clinical management because, right here and now we see people whose clinical circumstances are affected by food insecurity. And so very reasonable to address that as part of clinical management. However, this is a population health issue. It would be much better to take a preventive approach. It'd be better if people were never food insecure. Policies are likely to have a big impact on people, on who is food insecure. And so that needs to be part of our response as well. So I really think these are things where we should be working at more than one level to address them.
What are your thoughts about restricting the types of foods to only healthy foods within SNAP? Do you think that will help or hurt people who have chronic conditions and food insecurity?
I'm strongly against this. For about the same money as the U.S. pays for SNAP, we do something called the mortgage interest tax deduction. So if you're a homeowner in the U.S., you can deduct from your taxable income the amount of interest that you pay on your mortgage, and as a tax expenditure, that winds up costing about the same amount as the SNAP program each year. People would find it shocking and absurd to say that we should when you get your tax refund, that we should only let you buy healthy foods with it because it will improve your health. It's likely to change, the food consumption, or at least the food purchasing. And there's no reason to think that people in the income bracket who have mortgages are less likely to benefit from eating healthy foods than other folks. But that's just a type of restriction that we would not do. SNAP, in my opinion, is not a health program, although it may have health effects. The purpose of SNAP, to me, as a safety net program, is to say, if you're in the U.S., no matter what your income is, you're not going to starve. We'll provide you some food assistance. And so from there, I don't support approaches that try to leverage that type of benefit to only particular foods. I think if you want to supplement SNAP by, as some programs do, offering additional funds to purchase healthy foods or things like that, then that's reasonable and may well be effective. But as an overall change to restricting the SNAP program, I'm not in favor of that, just because I think it really sends the wrong message about why we're doing the programs.
And the last question is, we have a bunch of questions about how to fund medically tailored meals as people are, they don't have money to pay for them, and if they are cost effective.
Yeah, so I'd say that's so the question about how to finance them is a really important one, and the question about whether they're cost effective is an open one at this point. We don't know. It's an important area of study. My opinion is I think they're likely to be cost effective in particular circumstances, particularly ones where people have combinations of social and medical vulnerabilities that put them at very high risk for short-term poor health outcomes and are unlikely to be helped by other types of interventions that might might require them to do more on their own, like a food subsidy or something like that. I think they're less likely to be cost effective in situations where people may be able to do more on their own, but that's speculation and we don't know. And I agree, with what I think is the premise of the question, that'll be key for the sustainability of these interventions to understand whether they're cost effective and in what circumstances to use them so that we can make best use of scarce resources.
Great. Well, thank you so much, Dr. Berkowitz. That was a fantastic seminar, and thanks for asking all the questions or answering so many questions. We couldn't get through all of them, which shows just how much interest there is in this topic. So thanks everyone for attending, and we'll see you next week.
Great. Thanks so much. It was great talking with everyone.